Many thanks for the opportunity to participate today. I'm thrilled to be here. I think anyone who knows me knows that I'm absolutely incapable of giving talks or speaking about valvular heart disease without highlighting the invaluable contributions of the multidisciplinary heart team. It's a passion of mine, so I'm absolutely thrilled to share a few of these thoughts with you over the next few minutes. These are my disclosures. So historically, the cardiac surgeon was kind of viewed as the gatekeeper for time and type of intervention offered for folks who have valvular heart disease. This paradigm has shifted dramatically, and we're in what I call like the new normal at this point. This is not up to one person at this point by far. There is a whole team involved, and this is a team that utilizes their various experience, perspectives, skill sets, all to come together to work and focus on goals such as this, as providing a holistic approach to individualized care for patients, to discuss detailed clinical scenarios, including psychosocial components, which can dramatically impact a patient's recovery. And I'm talking about motivation and things like this. Review imaging to determine, yes, technical feasibility while keeping patient goals and wishes front of mind, utilizing shared decision making to deliver optimal patient experience and offer unparalleled clinical outcomes and procedural safety. So these are the goals that we're striving for in this new era as the paradigm has shifted toward a real heart team construct. And who's comprising this heart team? What does this mean? So the folks listed on the screen here, as Dr. Yadav so pointedly and appropriately said, the patient is at the center of all of these discussions and should be the focal point of the heart team here. But all of these folks really comprise the core people involved in the heart team at this point. We have interventional cardiologists, valve program coordinators, cardiothoracic surgeons, cardiac navigators, cardiac imagers, the clinical research team, advanced practice providers, and referring cardiologists, absolutely an integral part of the heart team. There is what I would refer to as kind of the extended heart team, all pictured here, where we include anesthesia, heart failure, electrophysiology, critical care, cath lab and operating room teams, sonographers, administrators, nursing. All of these folks come together, and all of their insights and contributions are absolutely pivotal to care and outcome of the patient. So this is what the heart team looks like today. We're no longer in a one sort of surgeon decides all frame of mind. Here we are. So this is now embedded in the guidelines. It's certainly not a passing fad, and as Dr. Duello very elegantly illustrated in her talk reviewing the 2020 guidelines for management of patients with valvular heart disease, this is indeed a class 1 indication in the guidelines that patients with severe valvular heart disease are evaluated or are to be evaluated by a multidisciplinary heart team. This is also mimicked in the Medicare, the National Coverage Determination for secondary or FMR patients that was published in 2021. They do insist on a heart team approach here as well, as you can see circled in red, require patient evaluations by not only an interventionalist, of course, but a heart failure cardiologist. And as you can guess, CMS, they're not just asking, you must do this to get paid. If you put a MitraClip in an FMR patient, you must have a heart failure cardiologist advise in terms of GDMT, resynchronization, and so on and so forth. So I've broken up this kind of the patient care continuum into 4 stops, if you will. This is broadly speaking, broad strokes. We have the workup procedure, post-procedure period, and then follow-up. So the heart team and all those folks that are comprised of the heart team really participate in each stop along the way. So the continuity of care really focuses on the relationships, the rapport, and the trust, and an overall impact on patient experience. And overarchingly, a functional heart team is key to programmatic development, optimization, and growth. I firmly believe this. So this is kind of a high-level overview of the patient journey from the referral to clinical disposition. And this is where I feel like the impact of the heart team is kind of the best illustrated, this portion of the journey. We're going to get into this. This is very high level. So let's talk a little bit more granularly. So at this point, let's talk about this referral to disposition and how does the heart team play roles in patients along these stops, along the care continuum, if you will. So before we actually physically see the patient in the office, our team, the heart team, is conducting a pre-consult chart review. They're going through looking at the past medical history, they're starting charts and entering things in our valve database, identifying the need for dual appointments, or does this patient only need to see cardiac surgery or interventional cardiology, so on and so forth. We're attempting to streamline testing to avoid multiple visits back and forth to the center, again, focusing on the experience piece. And we're making initial contact to build that relationship and that rapport right off the bat. We're going to take great care of you. We can't wait to see you. So in the initial consult notes, Vivek and I, we just had a conversation about this. I feel like it's just so critical, being kind of the source of truth for all the initial, for all the subsequent encounters that the patient has with our team. But, it's important for the past medical history component, and then also this surgical risk stratification. Yes, an STS score is a great jumping off point, but that certainly doesn't tell the whole story. We're initially looking for folks who would be considered research candidates. And our mantra, and I've learned this from working with Vino for well over a decade, is that all patients are to be considered research candidates until proven otherwise. So we're taking a look at what testing or advanced imaging might be required. We really embrace a navigator-led care experience. And when Bernie Marcus founded the Marcus Heart Valve Center back in 2011, this was one of his foundational pillars, where he felt extremely strongly about a navigator-led experience so that the patients, families, and caregivers had a go-to person to really usher them through what can be very complex and nuanced in a kind of a fearful situation. So the navigators on our team, they're wonderful. The nurses by training, they really focus on education and experience for the patients. Our valve coordinators are responsible for patient tracking and workup. They are managing the database. We use a program called Valve Track. It's an application to keep us all situated so we don't lose people. And they compile testing results and incidental findings, any clearances, so on and so forth, and any consultations that might be needed to work these patients up to present at the multidisciplinary heart team meeting. This is a lot that goes into this initial point on the care continuum from referral to clinical disposition. So I'm going to take one moment and talk a little bit more about the valve team meeting itself. Referenced this in his talk. So we spend a total of 2.5 hours every week in our valve team meeting. It's a multidisciplinary group. On Thursdays, an hour of straightforward aortic patients. On Friday, an hour and a half of complex aortic, mitral, and tricuspid patients. So the valve coordinators lead these meetings. Patients are worked up and presented in a very standardized and methodical fashion. We utilize our advanced imaging and our phenomenal cardiac imagers. Dr. Mabasri is one of them, to really have an interesting, robust discussion in a very respectful, open forum about what's best for this patient. There is real-time documentation going on in the background by one of the advanced practice providers. We call this a heart team decision note. This is listed as a progress note in Epic, very transparent. We want everyone on the care team to be able to look and see what was discussed at this meeting, what are the concerns, what was the final disposition, what are the next steps, and we want that to be very transparent, as I said. I do want to take a moment to highlight our colleague, Dr. Prasad Dasi from Dasi Simulations. He and his team at Georgia Tech are participating in absolutely pivotal work at this point in predictive modeling. And their simulations are extremely influential in terms of, if we have a complex patient with a concern for an issue, what can we do to circumvent any sort of procedural issues or safety concerns? And they do participate in our valve team meeting as an extended member of the heart team. This is just a brief example of some of the work that Dr. Dasi and his team do. Here we have two patients, one undergoing an evaluation for TAVR but has concern for coronary occlusion, and the other, again, a TAVR consideration but does have a concern for significant PVL given his calcium distribution and so on and so forth. So without getting into the details here, you can see that on this patient, yes, there's a very high risk of coronary occlusion, that very scary, huge nodule, huge chunk of calcium in the right coronary artery there, and significant gaps identified for this patient if they were to undergo TAVR. So these predictive models are incredibly influential, and these simulations did alter our plan dramatically. These patients were no longer taken down a TAVR pathway, but instead referred for open surgical treatment, and they both did very well. So our second stop along the continuum, if you will, this is the procedural component, from shared decision making to procedure. So after our valve team meetings are complete, we call all the patients and let them know what was discussed and what the next step or action items might be. And we participate in a shared decision making process. And this really falls to the entire team to focus on the patient experience and so on, to make sure people know what the expectations are. We want to set proper expectations right off the bat, because otherwise you'll be set up for disappointment and so on. The APPs are utilized if there's a very complex treatment plan, but I'll tell you, our nurse navigators and our valve coordinators are super knowledgeable, very, very high level, and they're able to convey even complex electrocautery techniques such as a lampoon or basilica to the patients, and very adept to explain that and also kind of talk them through the shared decision-making process. The pre-op assessment, including education and H&P and labs and things, our APP spearhead that. And then clinical documentation, that's another of my passion points in terms of how that does impact how a DRG is assigned, and how you are essentially graded for taking care of how sick your patient is, the acuity, the clinical acuity, and that in turn speaks to reimbursement. Another talk, another time. This is just an example of our shared decision-making tool that our entire team put together back in 2021. I won't read through this, but this is a tool that we actually send to patients prior to their visit, prior to their consultation in their new patient packet. And they're questions that we want people to come to the visit having thought about. And I'll just give you an example in terms of what are you not able to do at this point in your life that you would like to resume? What's your most feared outcome? What would you like us to know about you? This just really sets the stage for these shared decision-making conversations and making sure their wishes are kept front of mind and in a very fine focus. The third stop, we're talking about the inpatient post-procedure period here, from procedure to discharge, again highlighting the phenomenal structural APPs who really spearhead this process and really work toward optimal post-procedure care, ensuring patients are on the proper trajectory and there are no concerns that they're kind of wavering off expected course. Evidence-based practice, they ensure timely and safe discharges and look at all the usual clinical factors, but things could be nuanced in terms of structural patients, for example, oral anticoagulants, who meets thresholds for event monitors and things like this. Our cardiac navigators, who really, they're just phenomenal women. They happen to be women at this point, but they've met the patient at consultation and really developed that relationship. They go into the hospital to see the patients in room at time of discharge and really go through discharge teaching, and also ensuring our TVT registry requirements are met, because that also is extremely important in terms of our compliance. Heart failure teaching, they ensure a follow-up appointment is in place. And again, if a patient has been started newly on an oral anticoagulant, specifically warfarin, or what does the monitoring look like? And again, all for safety and communication with referring providers. And kind of the last stage here is from discharge to office visits. We do consider these structural patients our patients forever, but the whole heart team really serves to act as a resource when the patients go home post-procedure for any clinical concerns. And believe me, we get all sorts of questions, from my groin incision to, I'm not kidding, what kind of sunscreen would you recommend? I got that question once. So really, happy to be a sounding board for all sorts of concerns. New event monitor results that our phenomenal APPs do keep very close eyes on anyone who goes home with an event monitor and any concern. Do they need to come in? Are they having a conduction issue? Is it new AFib? How do we manage that? We see our post-structural patients, it should say post-structural, not just TAVR, at 30 days and 1 year. This is mandatory data points collected by the TVT registry. We prefer these people to be seen in person, but sometimes that isn't an option due to living out of state or vast distances or issues with transportation. So telemedicine is an option there. And these are the things we're looking for in terms of valve function, PVL gradients, but quality of life and symptoms. We're so interested in how these people are feeling, because if you go back to that shared decision-making tool, the one comment about, what would you like to do now that you're unable to do now that you were previously able to do, they're very pointed in what they want to accomplish with these procedures in terms of quality of life. And that's how I personally find it the most gratification in seeing the results here. TVT registry, as you're all aware, and then communicate any concerns or medication changes at these points and follow up with the referring provider. So the heart team, as you can see, really participates through the entire care continuum. I think overarchingly we invested a lifelong relationship with patients. We want people to stay within our care unless they leave the state for some reason. So I think we strive to educate the patient and family on the disease process and treatment options to ensure the information is not only easily accessible but also digestible. Utilize visual aids, the shared decision-making process, which I touched on. Setting those realistic expectations and optimal experience is critical. You want your program to be differentiated by this. Provide ideal communication with the patient families, caregivers, and also referring provider. I can't stress enough that we do consider them an integral part of the heart team. We take care of the patients when there's this lovely partnership, but then they go back to the local referring cardiologist for optimal care and ongoing management. And we strive to establish a healthy, lifelong relationship and continuity of care. So just in closing, I'll kind of summarize the power of the multidisciplinary heart team. I think is absolutely, as I said when I started this, just invaluable. It does illustrate a true collaborative care model. We communicate via high-level, transparent discussions, document our concerns, contingencies, and any treatment decisions in the electronic medical record for transparency, emphasizing safety for patients as an absolute priority. We safeguard optimal short and long-term clinical outcomes, strive for ideal patient experience, establish a healthy lifelong relationship, and finally ensure mutual trust and respect within the team itself. So with that, I'd like to thank you for your attention, and I am open to any questions afterwards if you'd like to see me, or feel free to email at any point. Thank you so much.